illiterate and were educated up to primary school. 7 attended middle school. 5 out of 34 subjects were HIV positive at the time of enrollment. Pharmaceutical opioids such as injection buprenorphine, injection pentazocine, and other opioids such as Foki and Doda, etc., were the most commonly used substances, and majority of the subjects used the primary drug through intramuscular or intravenous route. So we analyzed these characters using one-way ANOVA test for significance, and we found that age of the patient, the education, the mean years of education, and duration of opioid intake, these were the significant predictors of follow-up. And one interesting finding we found was that family type. As we all know, in majority of the psychiatric disorder, we find that joint family promotes a better compliance, better adherence, and better social support, and at the end, a better outcome. But in this, what we found was the nuclear family was a predictor of better follow-up. Maybe it's just a hypothesis. It may be due to the decreased social stress and the financial stress on the patient. Further, we analyzed the various domains of WHO quality of life BREF scores, and we found that social relationship domain that consists of basically the satisfaction or the perception of the patient towards the personal relationship, the sexual life of the patient, and the relationship satisfaction from about the cooperation from relatives was a significant predictor of follow-up. Statistical analysis of various socio-demographic characteristics yielded that predictors of good follow-up are younger age, more years of education, and belonging to a nuclear family. Lesser duration of opioid intake was associated with longer follow-up. Better social relationships were, as evidenced by social relationship domain score of quality of life, predicted longer follow-up. Other characteristics analyzed did not yield any significant association. So, with the results, we can conclude that younger age, better education, nuclear family, and lesser duration of opioid intake predict better follow-up. Social support systems promote longer follow-up, but there are various limitations to the study, that the sample size was very small and the duration of follow-up was very less. It was just 3 months. And also there are various parameters which should have been studied apart from these parameters, such as various biochemical parameters and various the medical condition of the patient, and also the psychiatric comorbidities the patient had. But to limit the spectrum of the study to study a few factors, we limited the study to these parameters to assess. So once we have understood the results, we need to understand that the interventions which we design, they should be such that we can tap the users at young age and at the beginning of substance use, so that we can improve the outcome. Establishing and enhancing social support systems should be one of the major intervention or treatment, as well as even before if possible. So family psychoeducation, group therapies, and occupational rehabilitations are the things we can do for the better outcome and better follow-up of the patient. Thank you. Thank you so much.
Thank you, Anbu. So any doubts regarding this paper? Any queries? So I had a doubt actually.
Yes.
So this younger age means what do you want to? So there are two interesting findings in our study. One is the younger age. Actually,
yes,
usually younger age means it appears that it will be a more chronic abuse or chronic dependency actually. Younger ages people. So second thing is many people will expect that usually feel that family, joint family, what you have, joint family is a good predictor. Okay, but
nuclear family is a good predictor.
For you, actually, why it has happened? Any reason?
So the two things. The first, younger age. Younger age, basically, in this case, the younger age, the duration of opioid, the larger duration predicted a worse follow-up, and the younger age of onset predicted a early better outcome, because when we were enrolling the patient, the young patients were still modifiable to change, and when they were presenting to us, they had various family responsibilities on them. So they were still amenable to change, and they were willing for to change their habits. But when the patients are aged around 50, 55, now they have lived their life, they do not want to change. They are saying that we are happy with what we have. So that is one reason. And the second, as I told you, the nuclear families in this study, what we found that nuclear families were a better predictor of follow-up. Maybe because in the joint families, mainly the patients who were enrolled with us, they were the main caregiver and the head of the family. They were the main earners of the family. So in a joint family, the financial stress is shared, and the maybe
Maybe there may be adequate supervision because there are 2, 3 family members may be there. I think they maybe have adequate supervision.
but in the what I have seen in families in which there is joint families in which there are dependent substances, there are so many tensions within the family members that they do not care. Whereas in a nuclear family, the wife, she has only one hope, and that is the husband or the patient who is coming to us. Now the spouse is very careful in these cases. In joint families, the even the spouse has some expressed emotions and issues with other family members, and they give up on the patient. But when there is a nuclear family, the children and the wife, since they are completely dependent on the patient, they, this is what I could gather from the family members. They
Thank
are
you,
more
thank
interested
you.
in getting the patient treated.
Thank you, Anupam.
Thank you, sir.
So next speaker.
Excuse me. Good morning, everyone. Do you know? Everyone knows that COVID hit all over the world very badly. Myself, Dr. Madhav Hundwe, junior resident, final year, JJ Hospital, Mumbai. In late 2019, a novel coronavirus started spreading from Wuhan, China, to all over the world. Currently, the world is struggling with the spread of COVID-19. The virus has increased the burden on health professionals and healthcare system in many countries. The number of cases continue to rise. Ultimately, the number of cases was successfully decreased due to lockdown and preventive measures. Exploration of the exploration into the impact of COVID-19 pandemic on the quality of life for the general population has shown substantial influences, especially it hit on the mental health. Many studies have reported that various symptoms are experienced during and after COVID-19 infection, but other studies have shown that post-COVID-19 symptoms are minimal for about 1 to 6 months after diagnosis, except for people with comorbidities. During the pandemic, families have encountered many issues, including mental health issues. Additionally, poor quality of life has been reported after 1 month for discharged COVID-19 patients, especially concerning physical and psychological aspect of well-being. Quality of life is defined as individual feeling of well-being in terms of satisfaction with important aspects of life. Individual preferred in defining their goals, choices, and expectation in life with help determine their quality of life. Why this study was needed? These studies have explored the quality of life of those who have recovered from COVID-19 at home without medical intervention. Therefore, we aim to assess the quality of life for recovered COVID-19 patient in post-COVID OPD at tertiary healthcare centers to study impact of comorbid psychopathology, post-COVID, and quality of life. Aims and objective to study quality of life in visiting post OPD of tertiary healthcare center, to screen and assess psychiatric comorbidities developed in patient visiting post-COVID OPD of tertiary healthcare center, to study various socio-demographical factors and COVID-19 related factors visiting the post-COVID OPD, to study correlation between quality of life and psychiatric comorbidities in patient visiting post-COVID OPD. Design and methodology. It was a cross-sectional observational study. It is done in outpatient department in tertiary healthcare center. Sample size 300 participants, including male and female. Ethical clearance taken from institutional ethical committees. Then this is the design of study. Then selection criteria, inclusion criteria, age group is 18 to 65, who have suffered from COVID-19 infection, including both sexes, and the willingness to participate document through written informed consent. Exclusion criteria, not willing to participate, is less than 17 and more than 65. and not accompanied by any reliable informant and non-COVID patients. Instrument and tool use, WHO quality of life scale, who QOL BREP scale. It is a 26 atom cell administered generic percentage. It is a short version of WHO quality of life 100 scales. It emphasizes the subjective experience rather than the objective. It includes 4 domains, two individually scored items measuring the individual's overall perception on quality of life and physical health. It is a 5-point Likert scale. Higher score reflect better quality of life. Second is SCL-19. It is a symptom checklist. It was utilized to screen psychiatric symptoms. It includes 19 questions. All items are rated on 0 to 4. More the score, was the symptoms. Then statistical analysis. Data was analyzed with the help of SPSS 22 software. Chi-square test for nominal data and unpaired t-test for ordinal data, and ANOVA test for internal data was applied to obtain p-value. P-value less than 0.05 was statistically significant in this study. Result and discussion. This study includes near about 73% male participants. Mean age was 48.96. And standard deviation 10.64. This is a clinical variables, including 100 patient was hospitalized. Then most of the patient was ICU admitted, that is 56%. Then there is most of means 80% patient, there was no death in family members. Most of the symptoms was breathlessness, that is 70%. Others are breathlessness, chest pain, weakness. Then residual symptoms, there was no residual symptoms in most of the patient. Then most common complication ARDS. Then other are fibrosis and mucormycosis. Most of the patient was taken medication. Then there was no any psychiatric ongoing medicine in the most of the patients. There was no family history in that COVID participants. And psychiatric medication, most of the patient, there was no data available or not taking any psychiatric medication. Then maximum patient does not have that medical comorbidity. Then 96% patient, there was no interpersonal problems. Correlation between quality of life and various variables. Correlation was significant on ICU admission, education, complication, then family death, medical comorbidity, biological function, substance use, interpersonal problem, then number of children and duration of admission. The correlation between SCL-90 and various variables, correlation coefficient was significant on education, then family death, medical comorbidity, then biological function, substance use, and interpersonal problems. This data shows that mean and standard deviation on domains of quality of life, and then that's symptom checklist. A result, SCL-90 was correlated with quality of life with increase in SCL score, then decrease the quality of life. The quality of life in patient of post-COVID-19 infection was found to be negatively correlated with SCL-90 score, and correlation was found to be statistically significant, p-value less than 0.05. Conclusion was COVID-19 has altered many aspects of people's quality of life. Then socio-demographic characteristic of individual with a history of COVID-19 related significant differences in quality of life. People believe about the impact of COVID-19 on general health, and history of hospitalization were mainly influenced by their health, functioning, psychological, and spiritual well-being. COVID-19 not only affect patient while they were infected, but impacted quality of life even after the remission. Thus, as psychiatrists, we have a greater responsibility that ever to reduce the impact post-COVID pandemic and prevent a latent pandemic on mental health. Limitation, it was a small sample size, near about 300. This study is OPD based. So inpatient COVID, we cannot assess inpatient COVID patients. Then this was a cross-sectional study designed after the outbreak of COVID-19. So here not able to answer whether the mental health of participant was worsened before the pandemic. Due to the limitation of a research condition owing to the pandemic, the study was carried out using a anonymous questionnaires and possible of bias. Then strength and future implication, a long-term follow up to understand various reasons behind course of psychopathology, minor as well as major health hazards of COVID-related mental illness and their relation with choice of intervention and impact on treatment adherence. References.
Thank you. Thank you, doctor. So the topic is open for discussion. Any doubts or any queries, you can ask the speaker. What is the timeline? Actually, so this study in which year did you recruit the study?
Sir, this just 6-7 months before.
So 2021. So last year.
Yes.
Okay. So I have a doubt actually. So two waves are there, no? So actually earlier is comparatively more severe.
Yes, sir.
So
It is between the first wave and second wave that time.
So once the cases have come down, this is the post-COVID study.
Yes,
actually,
sir.
that is the first thing. So after did you point anywhere that this is after the peak you have collected after the peak? So so many months after the peak, this study was carried out like that. Anything was mentioned in your study? Because what I want to suggest stress is because after the peak, once the complications comes down, if the complications have come to zero, the quality will be definitely, it will be high. Okay, quality of life. So do you feel that the timeline should be mentioned?
These studies are done after first wave, mostly just near.
So after the peak, after how many months after the peak did you mention?
After 6 months.
6 months. Okay, thank you.
Okay, thank you, sir.
So the next speaker.
I can see it. Yeah. Hello, good morning, everyone. Today, I'll be presenting my paper on the topic motor coordination, neurodevelopment, and behavioral problems in extremely low birth weight survivors during first 4 years of life. Continued advances in neonatal intensive care have led to increased survival of extremely low birth weight children, but they're at higher risk than normal birth weight children for neurodevelopment, behavioral, and motor problems. These factors influence academic achievement at school age because executive deficits might affect school performance and social and adaptive behavior. Existing infant and preschool follow-up studies have focused largely on the risk and sequel of severe neurodevelopment disabilities, while little consideration has been given to other important domains of development, which is language or behavior, which together with motor and cognitive functioning form the building blocks of later social, behavior, and academic success. Moreover, very few studies have been done on ELBW children at the age of school entry, which is at the age of 3 to 4 years. The majority of academic achievement deficits are evident at the time of school entry, thus indicating that the neuropsychological assessment at this age is an essential tool for preventing difficulties. The problems diagnosed at this time are indicators of future and mental disorders. Thus, neurodevelopment, motor, and behavioral problems in ELBW children was assessed at the age of 3 to 4 years. The primary objective of the study was to compare the motor coordination, neurodevelopment, and behavioral problems in extremely low birth weight children, and it was compared with the normal birth weight peers using appropriate assessment tools. While secondary objectives were to find out various factors affecting these problems and the relationship between birth weight and the problems within various subgroups of ELBW children. It was a case control study, which was done between April 2019 and August 2020 at IPGM and SSKM Hospital. The motor coordination, neurodevelopment, and behavioral problems in ELBW children were assessed, and they were compared with equal number of controls who were age-matched and were chosen from the community. The protocol was approved by the Institutional Ethics Committee, and informed consent was taken from the guardians of each participant. After viewing 200 children with low birth rate who completed 3 to 4 years between February 2019 and April 2020, 30 LBW children who satisfy the inclusion and exclusion criteria were selected for the study. The inclusion criteria being the children were ELBW, who were 3 to 4 years of age at the time of assessment, and the consent for participation could be obtained from the guardians. While the exclusion criteria was if there was any major congenital abnormality or chromosomal anomaly, or children with cerebral palsy, or those who were not giving consent. 30 children with normal birth weight who were age matched with the cases and gave consent for participation in the study were chosen as controls from the community. And the exclusion criteria was that if there was any associated intellectual disability or they were having any concurrent participation in another trial. Both cases and controls were assessed for motor coordination via pediatric balance scale. Bailey scale of infant and toddler development was used for neurodevelopment problems, and childhood psychopathology measurement schedule was used to assess behavioral problems. Statistical analysis was done via SPSS. Students' independent sample t-test was applied to compare normally distributed quantitative variables, while Mann-Whitney test was used to compare continuous variables which were not normally distributed. One-way ANOVA was used for comparison among more than 2 groups, while chi-square test was used for categorical variables among the groups. P-value less than 0.05 was statistically significant. Coming to the results, there were 3 subgroups of ELBW children, less than 750 grams, 750 to 900 grams, and 900 to 1000 grams. When the baseline characteristics of the 2 groups were compared, it was seen that the bronchopulmonary dysplasia, necrotizing enterocolitis, use of postnatal steroids and surfactants was statistically significant among child factors, while maternal age, education, low socioeconomic status, and use of antenatal steroids are statistically significant among maternal factors. Neurodevelopmental problems were assessed using Bailey's 3 scale, and more than 85 was considered as an average score, while less than 85 low and less than 70 was considered as delay. We can see that the children in NBW group performed better than ELBW group, and as the birth weight decreased among even in the ELBW, the scores further decreased. That was same for Bailey's both motor and cognitive score. These were the risk factor for a child and maternal factors. When the Bailey's language component was compared among the 2 groups, it was seen that 66% of the ELBW children and 80% of the NBW children performed above 85, and this was not statistically significant. Motor problems were assessed using pediatric balance scale, and the cutoff was taken as 48, which was 95th percentile of the normal population. Here also we can see as the birth weight decreased, so did the scores in the ELBW group, and they performed comparatively poorer than their NBW peers. These are the risk factors, commonly being the abnormal motor scale of milestones, BPD, NEC, and use of postnatal steroids in maternal age. Behavioral problems were assessed using childhood psychopathology measurement schedule, which was developed and standardized by Malhotra et al. The cutoff score was 10. That means the children who scored more than 10 were considered to have behavioral problems. And the mean CPMS scores were 16.7 versus 8.4 in ELBW and NBW groups respectively. Here also it was seen that ELBW children scored more on CPMS, and as the birth weight decreased, so did the CPMS score increased among even the subgroups of ELBW children. The risk factors were ELBW, maternal age, birth order, and low socioeconomic status. In our study, we compared motor coordination, neurodevelopment, and behavioral problems of 30 LB2 children, which were compared with NBW children. And the assessment was done by Bailey 3 scale for neurodevelopmental problems, which has not been used commonly because most of the studies have been done using 2nd edition. We found that ELBW children had lower Bailey's motor and cognitive score, while the language score did not differ among the 2 groups. This might be due to intrauterine growth restrictions on children in the ELBW group. In our study, the number of children having very low Bailey score increased at the birth weight decreased, And very few studies have compared Bailey score in subgroups of ELBW, which made our study unique. There have been very few studies done on motor development in the first few years of life, and ELBW had more motor problems as indicated by their low PBS scores. Moreover, there were trends for lower birth weight infants to have less motor coordination, as we saw in the pediatric balance scale scores. And motor disorder when present interfere with the overall maturity of the child due to reduction in quality of interactive possibilities that guide the development of socialization, self-care, cognition. ELBW children had more behavioral problems, IBUCO has seen in our study. And in Indian context, CPMS scale has never been used before to assess behavioral problems at such an early age of school entry. The limitation of my study was it was a small sample size, it was a cross-sectional design, and we were unable to include children who were born the same institution as control group. The take-home message over here is, though the advances in perinatal care has increased the survival rates of ELBW children, but still they are at a risk for neurodevelopment, motor and behavioral problems, which was seen in our study. And these difficulties, if they persist into school age, they can hinder child's school performance and overall functional outcomes. Therefore, early identification of these problems before 4 years of age, like in our study, would help to predict children at risk for developing problems in future, enabling intervention before school entry, better counseling of parents, and better resource allocation. Conclusion was that yes, ELBW children are at higher risk than the term-born NBW counterparts, and these are at high risk children who need multidisciplinary follow-up and early developmental intervention for optimal future outcome. Our study highlights that these problems can be diagnosed early prior to school entry, as seen in our study using appropriate scales, and diagnosing these problems early would enable early intervention before school entry so that ELBW children achieve a similar functional outcome as their normal birth weight peers. Thank you.
Thank you. So any doubts or any queries from the audience? I have a doubt actually. This you have ruled out, you have excluded the intellectual disability, no?
Yes, sir.
So mental retardation. So in your title or even in your one of the aim is you are assessing the neurodevelopment.
Yes.
Okay. So intellectual disability is a part of a neurodevelopment disorder. It is the major chunk of the neurodevelopmental disorder. So if you are removing the major chunk from your study, so how can you explain your results actually?
Sir, I had to remove because when there's intellectual disability, the scales which I use in other domains, they would have given a poor result because the children won't be able to understand the instructions which I'm giving for the other scales. That was the precise reason where I had to remove intellectual disability it was used as exclusion criteria.
Okay, there are no scales to pick up those areas.
No, sir. The thing was that that if the scales are applied, those were verbal scales, so the children won't be able to perform better, won't be able to understand the instructions.
Even you have excluded, I think, the children with congenital anomalies also.
Yes, sir. The similar reasons, sir.
Yeah. So because many children with neurodevelopment have associated. One of the main etiology of neurodevelopment is genetic etiology, and they have some types of congenital anomalies. So if you remove the children, so how can we generalize that result? Actually, we can. You got my point, no?
Yes, sir.
Okay, very nice study. Thank you.
Thank you, sir.
And the next speaker.
Good morning, everyone. I'm Dr. Syed Zainab from Department of Psychiatric Carter Medical College and Hospital. Today, I'm going to say about a study on social demographic profile, impulsivity, psychiatric morbidity among suicide attempters. Introduction. Suicide is one of the 10 major causes of death in India. 90% of persons who die from suicide satisfy the criteria for one or more psychiatric disorders. Most people have notably mood, substance-related anxiety, psychotic and personal disorders, with comorbidity being the common one. And attempted suicides were 10 to 20 times more frequent than the fatal suicides. And understanding the impulsive suicide attempts is necessary for effective interventions in later lives. Coming to aims and objectives, to study the social demographic profile and psychiatric morbidities among the suicide attempters, and to assess the impulsivity and intention of suicidal attempt, and to compare the clinical and socio-demographic profile of impulsive and non-impulsive ones. Methodology, it's a cross-sectional study. The study setting is in medical surgery and psychiatry wards of tertiary care hospital. The study period is about 1 year. The sample size is 65 and the consecutive sampling was done. Study population, inclusion criteria, more than 18 years of age people who attempted suicide, and the time interval between the suicide ideation and attempts within 30 minutes are included in impulsive suicide attempt and others in the non-impulsive group. When coming to exclusion criteria, and those people who had serious medical conditions and those who were not willing to participate in the study come under exclusion criteria. Next. The ethics committee clearance was obtained prior to the study, and after obtaining written informed consent, socio-demographic and clinical details were obtained using a semi-structured proforma. Psychiatric morbidity was assessed using the ICD-10 criteria, and impulsivity was assessed using Barrett's impulsiveness scale, and suicide intent was assessed using the Beck suicide intent scale, and chi-square test was used in the study, and data was analyzed using SPSS software version 17.0. Welcome results and discussion. And the first slide shows the distribution based on time interval between the suicidal ideation and attempt. The impulsive ones are about 70.7%, and the non-impulsive ones are about 29.3%. The study is in accordance with the Lingesh study, where the proportion of impulsive suicide attempt is about 60 to 65%. When coming to the distribution of type of attempt across the age groups, the most common age group who attempted suicide is between 18 to 25 years of age group. And for impulsive attempts, also same age group is the most common one who attempted it. When coming non-impulsive attempts, 26 to 35 years age group are the people who attempted the suicide. When coming to gender, distribution of type of attempt across the gender, the most common people who attempted the suicide are females one, and I did not find any significant association between the gender and the type of attempt. When coming to marital status, 55% of the people who attempted suicide are married ones, followed by unmarried ones. Next comes some distribution type of attempt across the previous attempts and socioeconomic status. Only 33% of the people who have the history of previous suicidal attempts, and 67% who did not have any previous history of suicidal attempts. When coming to low socioeconomic status, 72% of people who attempted the suicide belong to low socioeconomic status. Coming to distribution of type of attempt across the occupation, unemployed ones are the most common one who attempted the suicide. That is 46% of the whole sample are unemployed, who attempted suicide are unemployed. Next, coming distribution of type of attempt across educational status. The most common people who attempted suicide is your graduated people, followed by primary school people. And the significant association is found between the educational status and the type of attempts. Next slide shows the type of attempt across the reason for the suicide. The first most common reason found for the attempting the suicide is arguments with the family or friends or any other people. Next, for when coming to non-impulsive suicide, the most common reason was financial constraints or loan. And there is association is found between type of attempt and the reason for the suicides. Next, coming to type of attempt across a method used, the most common method used was poisoning, and among that organophosphorus poisoning is the most common one. And this study is also similar to study by Kosraj et al., where the most common method employed was poisoning. Among them was organophosphorus, followed by calitrophes. Next, the distribution of type of attempt across the history of psychiatric disorders. There was only 74% of attempted suicides have a psychiatric diagnosis, where 26% of attempted suicide do not have any diagnosis. And the most common diagnosis was severe depression. While coming to impulsive attempt, the most common diagnosis found was borderline personality disorder. When coming non-impulsive attempts, severe depression is the most common diagnosis, and the strong association is found between the attempt and the psychiatric disorders history. When Saho et al., he also said the presence of psychiatric diagnosis was present in 70% of the cases, of which depression is the most common one, followed by adjustment disorder. But et al. Also reported BPD was significantly associated with impulsive suicide attempts, which was similar to our study. And other two other people, Simon and Spokers reported impulsive suicide attempts were less depressive than non-impulsive ones, which was in accordance with the study. When coming to distribution of type of attempt across impulsivity score, we found that impulsive attempt people had higher BIS scores when coming non-impulsive attempts, and the strong association found between the impulsivity scores and the type of attempts. And Garka et al. And Wojnar et al. Also reported the high impulsivity scores were associated with impulsive suicide attempts, which was also in accordance with my study. Next one, the distribution of type of attempt across the suicide intent scale score. We found only Low scores are found in the impulsive attempt. That is only 59% of people have an low BEX score. When compared non-impulsive attempt, people have higher scores. 52% of people have higher suicidal intention, where for non-impulsive attempt. P-value is significant. And Dyson Hedmore et al. Reported the low suicide intent score in impulsive suicide attempts, which was similar to my study. The limitations of my study are the sample size was small, the study being conducted in tertiary care center, results may not be applicable to community. And since this was a cross-sectional study, causal relationship could not be established here. Conclusion, 74% of total suicide attempts had a diagnosable psychiatric disorder, and severe depression was the most common diagnosis, followed by borderline personality disorder. The proportion of impulsive suicide attempts was about 70.7%. And impulsive suicide attempts were found to be significantly associated with 18 to 25 age group, educational status, reason for the suicide, method of attempt, high impulsivity traits, and low suicidal ideation or intention. Thank you.
Thank you. Any doubt from the audience? So your study has a very good take-home points, actually.
Yes, sir.
A very nice study, and your study is in tune with the real scenario. Actually,
Yes, sir.
borderline personality disorder is one of the major disorder.
Mm.
So I have a doubt in the study. So one of the commonest diagnosis, axis 1 diagnosis, is borderline personality.
Personality.
So what about the substance use?
We have, sir. I have the AUD is alcohol use disorder
Oh,
only, sir.
so that,
So,
but it did not has any significance.
No significance was found, sir.
So
I have the
alcohol.
sample was females were the more common one in my the study, and the attempted people are more females, and in our communities, females are they're not.
And another thing is the common age presentation of the impulsive suicides
Yes,
is
sir.
like what is your common age?
18 to 25 years of age.
So that is
sir.
the common age actually.
Yes.
So because so in adolescence, from that is the transition from adolescence to adults, and it is the most common cause for suicide also, because in that case the brain is maturing still. Okay, the frontal lobe is the frontal cortex is still maturing. That is the reason the inhibition from the frontal cortex is not so much, and the takeover by the amygdala and all these areas. That is the reason why this adolescence, because basically I'm a child psychiatrist, because I want to show some light why this why adolescence, particularly that particular age group, is having high propensity to cause suicide or even a suicide attempts. Okay, very nice study. Thank you.
So much.
Thank you.
Good morning, everyone. Myself, Dr. Nikita, second year postgraduate from Gandhi Medical College, Hyderabad. Today, I'm here to present a study on referral pattern to Department of Psychiatry during COVID period in a COVID-19 nodal center, a descriptive study. Introduction, the consultation license psychiatry is a study, practice, and teaching of the relation between medical and psychiatric disorders, and it serves as a bridge between the psychiatric and the other specialties in a tertiary care center. So the consultant liaison psychiatrist deal with a broad range of psychiatric disorders, the most common being anxiety, depression, and disorientation. SARS-CoV-2 is a novel coronavirus which was first detected in Wuhan area, China in December 2019, and it has become an international pandemic affecting people all around the world, raising anxiety, stress, and increased financial burden, which is the effect of unemployment. The isolation and lockdown during this pandemic, it had several negative mental health consequences, either due to family separation and the stress related to socioeconomic consequences of the pandemic. And during this pandemic, sleep disturbances were also noticed. And the unintended consequences of the lockdown, it was a serious illness in some patients with alcohol use disorders. So this study took place in a tertiary care center, which was converted into nodal COVID-19 center during the COVID-19 pandemic. The aim of the study is to study the referral pattern to Department of Psychiatry during COVID period in a COVID-19 nodal center. The objectives of the study is to assess the causes for the reason to referral to the Department of Psychiatry during COVID-19 period, and to estimate the referral rate to the Department of Psychiatry. The study design, it is a cross-sectional descriptive study, and the study period was around 6 months from May 2020 to October 2020. And the total admissions during the study in this tertiary care center was 14,000, and the sample size was sample size for the study was 137. The reasons for referrals were documented in the study, and the psychiatric diagnosis was determined using ICD-10 criteria. And all the individuals who were referred to the Department of Psychiatry were COVID positive. The statistical analysis, it was done by using SPSS software, and the descriptive analysis was done in terms of means and standard deviation for continuous variables and frequencies with percentages for ordinal and nominal variables. Coming to the results, among 14,000 patients were admitted in the tertiary center during this study period, and out of them a total of 137 patients have been referred to the Department of Psychiatry during the COVID-19 period in the period of 6 months. This table shows the socio-demographic variables, including the age, gender, religion, education, and occupation of the patients. And table 2 includes ICU and non-ICU admissions, and table 3 includes comorbidities present or absent, and table 4, it includes reasons for referral during this period, which includes alcohol-related disorders, altered behavior, psychiatric illness, attempted suicide, sleep disturbances, fearfulness, and others. And table 5 includes diagnosis of disorders based on ICD-10 criteria into alcohol dependence syndrome, delirium, depression, psychosis, intentional self-harm, and acute stress reaction. Discussion, the referral rate in the present study was found to be 0.98%. And the mean age of the patients was 47.12 years who were referred to the Department of Psychiatry. And among them, majority of the patients were males and Hindu by religion. 56 out of 137 patients were illiterate, followed by 30 patients who have completed their higher school education. And majority of them were semi-skilled by their occupation, followed by unskilled by occupation. And the majority of the referrals were from non-ICU unit with 93 patients, and 44 patients were referred from ICU unit. And only 21 patients were found to have medical comorbidities like hypertension, diabetes, and thyroid problems. And most of the patients didn't have any medical comorbidity. The reasons for the referral, the most common reason for referral during the study period was found to be altered behavior, which is followed by alcohol-related disorders in 35 patients. And 19 patients had previous psychiatric illness, and 14 patients were referred in view of fearfulness, and 11 had sleep disturbances, and 4 were referred in view of attempted suicide. And the diagnosis was made according to ICD-10 criteria. Out of 137 referrals, the most common psychiatric diagnosis was found to be alcohol dependence syndrome with withdrawal state, followed by second most diagnosis with delirium in 30 patients, and 25 had psychosis, and 8 were diagnosed with depression, and 2 patients were found to have acute stress reaction. And 21 out of 137 patients, they were found to have no diagnosis. So the conclusion of this study is the most common referral to the Department of Psychiatry was altered behavior, and the most common psychiatric diagnosis was found to be alcohol dependence syndrome with withdrawal symptoms, with the referral rate of 0.98%.
Thank you. So any questions? Very nice study. So one doubt I had, so the same question as like as earlier speaker, what is the timeline? Because when you have conducted the study is important. So after the COVID infection, suppose immediately means you will have a withdrawal. Okay. Yes. So after a span of suppose actually whatever the major post-COVID psychiatric complications that occur will be in a later period. Okay. Yes. Secondary to the indirect effects of COVID. The psychiatric complications are secondary to indirect effects. Yes. Okay. So if we do a study immediately after the COVID infection, So after the patient is admitted, majority will have withdrawal symptoms because the second, all those are withdrawal or acute complications, psychiatric complications. So what is your time frame? So when did you enroll your patients? So after the admission, immediately after that, once the patient came to COVID center, immediately after you have, so the immediately you have taken the history, you have recruited, or else did you put any gap between the admission of the patient into the COVID hospital and referral to your psychiatric center?
Patients have admitted in view of COVID positive, sir. So after admission only, we have taken.
You have taken.
Yes, sir.
So this is another important thing is this is the COVID center. Actually,
Yes,
it is
sir.
not like a general hospital
yes.
setting. So that is another important point we have to take. So we cannot generalize to everywhere
Yes,
because
sir.
it is a COVID center. A patient already admitted due to COVID,
Yes, sir.
already admitted, no?
Yes,
Or
sir.
already taken OP treatment.
No, sir. They have admitted in view
So
of
they are
COVID.
mostly a severe COVID patients. Okay.
Yes,
So, and they have done, and your study was recruited immediately.
Yes, sir.
Once the patients were admitted, if they have symptoms, they have referred.
Yes, sir.
So a majority have alcohol withdrawal.
Yes, sir.
Okay. So keep, if you keep aside the alcohol withdrawal, what are the other main psychiatric complications in your study?
Second is the delirium, sir. And
Okay.
other
So
one
that is a part of even alcohol withdrawal. Sometimes or else even delirium secondary to COVID also.
Yes, sir.
Okay.
And depression was another thing.
Depression,
Yes, sir. And some patients had psychosis. Like,
psychosis.
yeah.
Okay. Thank you. Okay. Thank you. Any other thing? So I congratulate all the speakers. Very good. They have presented a very good research papers in their field. All the best to every speaker. Thank you.
I would like to ask the chairperson to felicitate our speakers. Dr. Anupam Yadav, please. Dr. Madhav Rao. Dr. Akanksha. Dr. Zainab. And Dr. Nitin. I would like to ask Dr. Akanksha to felicitate our chairperson. Thank you so much, everyone. This session is over. Mm.